Hello, everyone. Thank you so much for joining this special roundtable discussion with Dr. Arwal, who is joining us from Afghanistan. I'm going to pull up his presentation now, and we're going to jump right in to his presentation. We're broadcasting live from the offices of the Division of Global Health Equity here at the Brigham and Women's Hospital, which is wonderful. And then this is being sent out to all people at PIH, mostly with a focus on folks in community health. But then we'll have the link available later on, also on some sort of file sharing network like YouTube, so that more people can see what Dr. Arwal has to present. And so by way of a short introduction, Dr. Habib Arwal was the director and founder for community-based healthcare in Afghanistan. He worked for over 25 years in this role, and he's now at Harvard Medical School as a research scholar in the Department of Global Health and Social Medicine, and he was also working with the NCDI Poverty Network. We recently met when he came into town, and I was very impressed with his wealth of experience, and I thought that it might be really beneficial to folks in our community health networks to hear more and then even have an opportunity to ask questions directly. And so without further ado, we'll go through a presentation to give some background, and then we'll have some questions at the end. So Dr. Arwal, thank you so much.
Thank you so much, and thanks for the time given to us, and we will share our experience with the people, with the teams. So, I introduced by Dan that I will talk about the community-based healthcare practical knowledge and experience what we have implemented in Afghanistan. You know that Afghanistan is one of the countries in, unfortunately, since 45 years, there is conflict situations, and but within this conflict situation in last 20-25 years, we try how to engage the community, and by this tool of the community-based healthcare in official included in the system of Ministry of Public Health. So let me share the some of the knowledge or experience. It's
Let me see. Let me try.
Okay.
Yeah.
And then, so this is just a map of Afghanistan. You know about these 34 of the provinces in Afghanistan, in around 35 million of the population is now for the Afghanistan. And this is the Kabul city, a capital of Afghanistan. And this is just in the photo with the previous president of Afghanistan, Dr. Ashraf Ghani beside me, and this is the team. What we run the community-based healthcare program. In this picture, you can see with the EMRO WHO main office, the Dr. Al Jazairi, and the team for the CBI program, community-based initiative in WHO. And this you can see the in Bangladesh and also in Indonesia, we have visited and we have presented our program, and they acknowledge, and they was happy with this for our visit, and we were so happy for the visit and see and learn from their programs. And this slides, you can see that when in 2009 there was American Public Health Association World Conference, and I have presented our community-based healthcare program during this conference. And you can see this is another team of Johns Hopkins universities, and Dr. Tyler, he was one of the founder of the Almata conference or Almata declarations, and the other teams of experts of the John Henry Perry, you can see here, and this was, and this is the, just for example, I brought and put some picture from in Oslo and Tromsø University for the global health in master public health program. So I presented the community-based healthcare experience in globally with them. And also this another one is in Korea, that there was another conference for training for the community health programs. And this also just, you can see some of the meeting and programs in the Ministry of Public Health with the key people of the government. For example, this was how every year in the last 25 years or 20 years at least, we have celebrated National Community Health Worker Days. And we have had a big conference meeting and talking. And this is the key persons of the task force, community-based healthcare task force members, and we are working at the national level, and we work in all 34 provinces of Afghanistan for the engagement of the community and strengthening of the community-based healthcare program. And for the next, you will see, and I will present something about the 3 programmatic approach for improving health, what is community-based healthcare, who is CW, where they perform in CW training and supervision and association, compensation, provision and supplies and recording job description. So these few points you will see in my presentation. First of all, we start from the 3 pragmatic approach for improved health or building of public health, which have 3 main pillars, which is the first, the disease-oriented approach, and second one is the service-oriented approach, and the third pillar of this building of the public health or the product improved population health is community-oriented approach, which is very important pillars of this building and this tool. So this is the we use for the community-based healthcare approach. And you can see that the explanation what I said in this 3 approach or 3 pillars of the stools. And the elements of the CBC program in Afghanistan, you can see here, this was the one important main departments of Minister of Public Health for engagement of the community and for the getting ownership of all health projects by the peoples and by the communities. The main elements of this, our community-based healthcare program was community health workers, community health supervisors, community health shura, or community health committee. I mean shura, if you are not familiar with this name. Shura is by our own language, they call community health committee, or any community leaders gathering is called shura. Family health action group, this was actually the women action group, but we changed in context of Afghanistan by the name of family health action group. This was helping future generation of United States with us for the implementation of this project and this elements. Family health house is another elements. When we after a few years understand the family health, how the health post should be developed more. So we call that family health house in some area. We increase some of the staff, for example, community midwife in each, some health post, we call that family health house, and it was supported at the beginning by UNFPA, that they was helping you with us for this. And also you can see, so the role of community-based healthcare program or department at the central level and also at the national level for the policy development, leadership and stewardship program, technical support, providing answer to provincial staff and ensure from implementation of the program. This was the key role of the CBC program. You can see in this picture, before at the beginning of this, Afghanistan is one of the mountain areas. and this is, and especially we have had a lot of problem for the patient, for the referral of the patient in the remote areas. So you can see that in remote area at the beginning, this people was out from the mountain area, carry out or refer their patient to the health center at the beginning, really, where you would not believe that's how the people use this. And secondly, at least they learn how to use the donkey instead of the maids to refer the people. And finally, we make a little develop, you see, another kind of a donkey to be safe for especially for the woman to refer for the delivery to the health centers. And finally, at the last years, we were reached to, by help of UNICEF, to distribute some of the communities around, a community ambulance, that is we call, you can see that very simple, small ambulance. It can walk in, it can run in the way there is no road, but only wait for the walking of the people. They can use this. So I mean, there's several steps of the community-based care in Afghanistan. We passed in the past 20, 25 years to finally we reach at the last to improve that community-based healthcare program for the safety of the patient in the community level.
Oh, could you go back to that for a second? I just,
Yes.
I want to clarify one thing, because we'll have questions at the end, but these pictures are so evocative, and
Yes.
for people who like community health, they're a lot of fun.
Yeah.
I just want to understand, the picture on the upper right-hand corner,
Yeah.
where the gentleman in the two shades of blue are carrying that gentleman, we've seen this type of shoulder-based ambulance. How far will these guys walk with someone like this?
They will at least from half to 2 hours.
2 hours?
Yes, because there was no road, there was no cars, and there was some houses. So they start. So why at the last we reached to this point to we build a family health house to them. If this is, for example, 50 houses or 100 houses,
Wow.
we develop their health post for the family health house to at least to help them for some safe delivery for the women or something for
like a halfway. And then the
Yes.
woman down here on the donkey.
And the donkey, this is from the same area, but after they use this, we try to show them how to use the donkeys a little safely by them.
Because it's more comfortable. I see that she has a
Yes,
large pillow
yeah,
behind her.
Behind her, and they can use it. It will be a little safe than the above. You see that
A little bit safer because it's
Yeah.
I can imagine the gentleman walking. It's quite bouncy, and
Yeah,
maybe they
yeah,
slip, and maybe they
Yeah, and so after that, we try to change this and find them there is, we call rickshaw. And this is a kind of vehicles, this is a sample, and this is, it can use it in this the simple, not a road, a simple way for the walking of the people to the village, for the villagers, so you provide them that.
Wonderful, great, thank you.
And in this picture, you can see this is my 25 years back pictures. When we start, at that time we start in 1996 by the name of VHV, Village Health Workers, Village Health Volunteers. We start this training, and we select some people according to the criteria in the village, and we start the training for them. And this is one of the experts was from Europe, and he came and wanted to see my program there in the village. And at that time, I was as a doctor for the primary health care of one of the health centers, small health centers. So you can see this slide. This is just a briefly community-based health care system in Afghanistan. As I said, there will be community health post. In the basic center for the health is health posts in Afghanistan. Health posts is included two. CW, community health worker volunteer. One will be male and another will be female from that. So we have had at the last before August 2021, what I understood that we have had 15,835 of this health post, and also community health shura, as before I explained, the community health leaders who are included in the system, 16,537, and then community health workers total from this health posts include 2 in each. So total number women and male was at that time 29,591. And family health action group was another elements of the community-based healthcare program. As I said, this was a women health action group, but we changed in context of Afghanistan. We involved the male too. It was around 6,176. And the CHS, for the supervision of this all community-based health program in each health center, we have had one CHS supervisor, community health supervisor, to supervise in their catchment area, in their health center catchment area, the community-based healthcare programs. And these are different elements. Small elements was under these 4 or 5 elements. They were developed. They work with for the community-based healthcare program in Afghanistan, for referring, for the outreaching. In this slide, you can see to the involvement of the community-based healthcare program in the generally for the Minister of Public Health or other programs. So you can see that it was more. And this is one of the health posts. You can see this, as I said, one male and one female from the village, from the peoples who are there. We select and we train them, and they are working for their community day and night because they are in the village, even if they are remote and they are staying here. CW eligibility criteria, how we select the CWs at that from the beginning. You know that 45 years back, or at least 25 years back, when we started this program. So there was because of the war and the conflict, the electricity rate was so down. So even there was difficulty in remote area to find educated people to include in the help us as volunteers. So we start to find some illiterate peoples and train them. So this was the criteria. Residential of the local area, age will be from 20 to 50, volunteer, motivated and interested to serve as CW, respected person from the area, and try to educate it if there was some person. But now at the end, of course, all of them are educated. CW were in volunteer and work part-time. Why part-time? For example, some of the teachers in the village school, they was working officially for the school, but part-time after their official work, they are working voluntarily for the community health programs. So helped by the community and organization and remuneration maybe in cash or kind, and the government not pay salary to CW. They receive incentive during national immunization day or any health program. If there was some campaign, they receive some of the salary, not salary, but some of the money as remuneration for them. So you can see all of the CW are the frontline health providers. It is at the village level. This is in the remote area, and especially community-based health program more focused at the beginning in the remote area. And at the end, we started in the urban areas. There's also another kind of the CW training what so you see this is a simple skills what they use it for nutrition to understand the children nutrition condition, and they got it during the training. The total duration of the training is 6 months, 3 phases of classroom training each 3 weeks. Practice what he or she has learned in the community, and so these were the duration of their training. At the end, they receive the kits, monthly kits we supply to them and give them medicine. What was they learned to use that simple things you can see that. And for this is for example, as I said, we train the uneducated people. So for the uneducated people, it was difficult to write one thing and to understand. So we try to use the pictorial document, pictorial intelligence, pictorial reference sheet. For example, you see if this is how the ORS they use for the children during diarrhea, and how can they give it or some medicine in the morning, in the afternoon, and how they understand in the night, what will be the sign of this to morning and afternoon and night for the uneducated people, to at least to understand this, to use this thing. And this is also a kind of training of them in and understanding how to put this document in the report in tally sheet, giving information for the people during their working or health education with the people. Role of CW in health service delivery in Afghanistan: enhance community awareness and participation or engagement, promote skilled birth attendance at health facilities, provide and promote mental care and promote antenatal care and promote prenatal and postnatal care. Providing birth spacing method, this was the main jobs for these people. Identify ARI, diarrhea, malaria, and other common communicable disease. Treat mild cases or refer complicated cases to the health center. Promote good nutrition practice. Promote hygiene and sanitation. This was a very important. Provide first aid service for the minor injuries. They were learned, they trained to how to provide the first aid service to the people, for the injured peoples. Ensure compliance of TB patients, the using of DART programs. You know about the DARTs in community, this was very important, and they promote psychosocial well-being, consultation patient on correct use of medicine, medication. So this was their main jobs during their practice. This slide you can see, we have had for the nomad peoples we have in Afghanistan, and for them we have a little different curriculums or manual for the training of them according to their disease, what they have, the nomad people among them, and how to, because they are mostly they are in moving, some for a few months in this place, in other months in this even. So we try to manage and how to train them, and you can see we train a lot of them, and we provide kits and something for. This is mostly the main jobs of the health education of the CW. They are providing some materials, some picture. You see, this is the community maps. Each of the CW should understand, and they should have in their area, catchment area, the community maps. In community map, they understand how many of pregnant women they have in their catchment area, and how they understand from the maps, and how many of if there is any case of tuberculosis or other, they should understand this. So this was the health education program, and these are also community health worker, what they use the program, and their village for the peoples. And this is also a number of acute diarrhea patients treated by CW during 1383 to 1391. This is by our own calendars. So they use a lot, they treat or they manage a lot of acute diarrheal cases, and also ARI cases that they use it during this to 2010, and also a number of cases related to health facilities and also in the health post. So we compare health post with the health facility. Health post was the beginning of health system at the community level, and health facility a little higher level of the health service. So we compare how much of this, for example, this case of this kind of service, health service provided by the health post, and how important and how involved. And this also the comparison of the health facilities and health posts for providing of the health service, and especially for the contraceptive. This was very important. We used the community health worker to provide contraceptive, a different kind of contraceptive for the people in the country. And generally, this is the percentage and role of the community-based healthcare program with the all system of health service program in Ministry of Public Health. You can see this all, as I said, in malaria, hygiene, and other. And this also you can see contraceptive service of them. Recording of the CW, how they record, even if some of them are at that time was uneducated or illiterate peoples. So simple record. National Health Management Information System, they recorded it and sent it to the National Health Management System. And they use pictorial tally sheet, as I showed it before, monthly activity report, and pictorial register in community maps. They use these tools for the recording of their service, health service in Afghanistan. Family Health Action Group is another elements of the community-based healthcare program under the CW. So they are usually implemented healthy practice in their own home and demonstrate them to the women living in neighbor houses. Means these family health action groups, most of the women with the children, they was a member of this family health action groups. They learn from their practice in their home, and they share other stories with the other women in their neighbor homes, village, and they share their knowledge and their output of their experience, and they learn from them. And also promote appropriate use of curative and preventive care from the CW and from health facilities. Inform CW about the pregnancy, birth, and sick women and children who need care. Encourage families to follow the CW recommendation for referral when necessary. Provide wider contact with the men and community. Men and community through men belongs to their own families to encourage their participation in the health improvement activities. So this was the main task of the Family Health Action Group, and this is the community health supervisor. As before I said, one another elements of the community-based healthcare program in Afghanistan. In each health facility, we have had the one CHS assist in training of CW, review and evaluate the performance of the CW and identify need for further training. Guide CW in the development and implementation of their action plan, and conduct regular supervisory meeting with CWs, ensure regular replacement of supply in CW kits, provide updated HMIS report according to this tally sheet which was prepared for you, and then they collected all from CW and make a report from that to the health facility, promote the health facility community collaboration. This was the main task of the sages. Role of community health shura. They are mostly responsible in have the role of how to mobilize the resources of the village, how to mobilize and how to help with the CW, to encourage them and work with them for the community support. So their role was very important in the community-based healthcare program. You can see the women health shura or community health committee when they have a monthly meeting in their village and talk about the health issues and how to inform to the CWs or to the health facility. So this was, and in the last 20 years especially, we have implemented CBC piloted project or intervention, family health house. Can we have some photos too? Yeah, family health house. This was one of the elements, as we said, this was a project which was needed, supported, because it was not included in the system of health to get fund from the Minister of Public Health. This was at the beginning when we piloted, that we got the fund from the UNFPA, and they supported us, and we developed, and we strengthened the health post to the family health house. Means we include one midwife in the health post with the volunteers. This midwife can solve at least the mother and child health care in their village. And Zaranj Mini Ambulance, what I show you, this was a project from UNICEF, enhancing access of mother in newborn to emergency service with UNICEF. This was community scorecard. This was another project from Johns Hopkins University for the engagement of the community. I will talk a little. Community-based first aid training by WHO. Because we understand in Afghanistan, unfortunately, a lot of war and fighting, and also the remote mountain area, most of the people got injuries. So we understand to strengthen the first aid training and learn more the CW about that, how to manage that. So we talk with WHO, and WHO support our programs and help us with this. Community scorecard was, as I thought about, this was one of the important projects, which was the we did jointly with the Johns Hopkins University and conduct a study for the future health systems. In another countries of the world, there was by the name of future health system. We in Afghanistan, the same system we use with the community scorecard. How to, for example, we engage the community in several, piloted in several provinces, in Garhar, Takhar, and Bamiyan. We, for the engagement of the community in all programs from the beginning, for the health issues, health program, for the planning and for the implementation and evaluation of the program for 3 processes. We try to, how can we involve simply the community, and also how do we ensure the community provide their simple resource and help for the strengthening of the community. For example, if there was needed for latrine, and in one of the health facilities, this was a big issue, or need for digging of well for the waters. So we try to, by this method, to encourage the people and involve the community to help, because there are no budget. They dig the wells and they, for example, make some places for latrine or something like that. So this was the project for the community engagement. And these are also the different kind of meeting, conference with the communities. And this is the one of the, in 2020, in 21, the beginning of 21, before, I guess, there was the project from NCDI Poverty Commission from Harvard. And this was supported in for the COVID-19 and youth project. It means the involving of how the youth who have NCD and how they are in COVID-19, their situation. We did a simple survey study in one of the provinces, and this was supported. And we involved the community-based healthcare program for the survey and study CHS and CWs, and we trained them and we gave them some training and we involved them and we got the report and we shared it with you at that time, if you remember. So this was another project. This is the just explanation of the community child and illness by the communities. And some of the challenges also we have had for the program of strengthening of or implementation of the community-based healthcare program in Afghanistan. It means it was not 100% successful, but we got the challenges for us. Insecurity was a big issue for implementation of all programs, including community-based. Because if, for example, we wanted to go to some remote village to implement some project for the supporting of community-based healthcare program, there was difficult because of security. This was one of the issues. But we try by the community leaders to they make facility in means to defend or to not allow the people or tourists or other people in their village when we are there. They trying to defend from us to be there and to provide some health education or some health program. And poverty and volunteerism, this is another issue. We in Afghanistan, we did not pay all the CW any salary. Just they got some during some campaign, some incentive or something, but not regular salary. And during, beside this, not paid, there was poverty. They need to at least to do something. This was issues for us because at that time, why we not pay anything? First of all, we have had some donors, but we try because the donor dependent issue will be for some time. And for the future, we will worry about that, how the government is not able to follow that. So we try to be at the beginning, volunteers and not pay, and main task on CW. CW in one village, all the NGOs or health and unhealth community projects going to the CW, you do this, you do this, you do this, and they're volunteer. So they did, but it was a problem, and it was a challenge. Funding, literacy, as I before, and culture, there are some things, for example, for the women in some area, it was difficult. Women should be men involved in the community-based care program. So many projects of different community programs, and now a big challenge is the government, because the present government think about that. This program is against of us. This program was against us because it was supported by United States during last 20 years, or from United States, the USAID MSH mostly support and help with us for these programs. We work for that, but they are supporting, they are helping us for funding or something. So because of that, the present government thought this program or these people are against of us. Wow. So especially among 30,000 of the volunteers, there are half of the 15,000 women. So you know that they have problem with this engagement of the women in some issue in some projects, unfortunately. Wow. Implication for the fragile setting of the program. CW and community engagement should be a center part of effort to address a health issue and fragile setting. Communities should be partners in the formulation, implementation, and oversight of CW program. Selection and training appropriate to context and collaboration with the community, age and marital status should not be criteria. Supportive supervision essential should be. So that this was some point, and including all community projects, an example of way to focus large global level donor funding to reach households of the priority population group who are by NGO that provide service which government are unable to provide, but at the same time support government in internationally defined priorities. Need to keep a long-term perspective on how CW program can become increasingly integrated into health system and sustainable for the long term. Afghanistan CW were never paid because the concern that the government would not be able to provide salary support when donor support would support this program, but after the no donors, so this would be difficult. Thank you so much. There is a lot of things, but just because of time, I quickly talk. I'm sorry for that, and hopefully to have some understand some of our knowledge in conflict country of Afghanistan for the community-based care. Thank you so much.
This is wonderful, and we had such a rich opportunity here to hear, but we also have 20 minutes left, so we can now get into some questions. I mean, there's so many ways to ask questions about this. So I'll start off, and there was also some questions in the chat. Let me make sure that. By the way, just quick question. Can you guys see us in the room? Matthias, for example, I know you were seeing us before. Can you see us physically in the room?
Yes, you are small, but you are there.
I've always been small in here, so we're good. So my question for you to start off, it's really quite an incredible story, and I think one that community health programs all over can learn from. So you have a country that up until the Russian invasion was peaceful, developing, and then after that, there was decades of strife. You got involved with the village health worker, the VHVs, yes. Village Health Volunteers, in 1994. Yes. And then through years of turmoil, you had a relative period of, I guess you could say, stability with the US-backed sort of government. And then when the Taliban came back in, yeah, there was this sense that this was a US program, even though it used international best practices. Yes. There was nothing, I think, in your presentation that looked unfamiliar to what a lot of programs have done in other countries. And it adapted for the unique, yes, Afghani context, but it looked very similar, you know, in terms of best practices. And so the program had to end. A big part of that being the inclusion of women, empowering women to have knowledge and access to services, access to goods, yes, that could then give people access to things like contraceptives and family planning and the like. So I have a couple of questions. One, where is the program now? Do you have a sense? Have you been able to connect with colleagues? And you know, in that transition of the Taliban saying, this is a US program, we're not going to support it in the same way, what has replaced it?
Thank you so much for the good question. Yes, it was, as I said, that unfortunately we try to strengthen the program, especially from after 2002, and the new peoples from the world, the involvement in Afghanistan, and especially United States. We try to to reform the health systems, which was before them in Taliban last period, and to start. So there was a quick survey by MSH in Afghanistan to understand how much of the population living in urban area and rural area and semi-rural area. So there was, after the survey, we decide according the health system should work according to the primary healthcare system. But the main strategy for the engagement of the people should be community-based healthcare program. So from that time, we started turning in. As I said, we trained the people, not only the community midwife. This was also one of our initiative to start in Afghanistan. So that we started, we did, and for the time after the US and other world people going out from Afghanistan and the Taliban is reached again to. So still I have by the telephone or by WhatsApp or sometimes by email with the people who are there. You know that in Afghanistan, as I said, 35 million of the population. And thousands of the people were working. There was expert of the health in the Ministry of Public Health and health facilities. But all of them are not out. They are not able to go out. They are still in Afghanistan. We have in contact with them. And even every night I get some call from Dr. Arwal, what should we do in this? How we do it? So I'm trying to share what I know, my experience with them, to do like this, to do it with the people, with the health experts who are still working there, with the private sector, and with some of the NGOs are still working there. And they are working with the NGOs because I'm not now with the Ministry of Public Health. So still they are calling me and so this program, what's your advice or what should we do? So I mean, still there are some programs, but at the beginning, the new Taliban government wanted to stop all the things. And that was stopped, and even now also it is not restarted actively. But at least the male CWs are working in some area. They are still working, but unfortunately they not get the support. For example, monthly we provide them some kits, some medicine and some medical instrument or medical things to use for the first aid and for the other health service delivery. So, but they not get. So at this situation, if we be able sometime to restart this program, they will be reactivated. And they are still alive and they are still want to work for their community, for them. But unfortunately, it is very weak now.
Wow. Wow, it's it's a real challenge when the momentum that you were building drops off. Now, we had a question in the chat about, that was a very specific question, but were the community health workers able to physically inject people, either women with a long-term contraceptive or children with immunizations? Was that part of their tasks, the ability to physically inject somebody?
Only for the polio vaccine providing by the volunteers in all over in the countries.
Polio. Oral polio.
Yeah, oral polio. And for the other vaccination or immunization, still there was not actively. But the developed health post, what we said, family health house, they are actively involved in that.
They were injecting at the family health house.
Yes.
Gotcha. Anybody out there have any questions about the community health program in Afghanistan? Well, they're collecting their thoughts about other questions. I'll ask another question. So you spoke about the challenges with paying, about inconsistent funding coming and going. And so that led the program to rely on volunteerism quite a bit. It also seemed like you had a large number of consultants and supporters, especially from Hopkins, that were showing how that had been done in other contexts. And that's long been a part of community health. You know, now there's this renewed interest in community health workers being a professionalized cadre. At the 3rd International Symposium on Community Health Workers that just happened in Liberia, in Monrovia, Liberia, that was a major theme, major theme. And so the question wasn't so much, why should you professionalize? I got the sense at that symposium that most people agreed you should pay them. The question now was how? And I think that's something that you guys were also, and I understood in your talk because you talked about how one of the challenges being volunteerism.
Yes.
And so the how. We don't have a lot of clarity on how we're actually going to make an international professionalized cadre of community health. A lot of times people say there's not enough money. But then if you think about for example, the US military budget in Afghanistan during those 20 years, billions and billions and billions of dollars.
Yes.
We have very good tools. You know, many people on this call have done these tools, use these tools themselves to cost out community health programs at national scale with professionalized, supported, stocked, the whole thing, educated, and they're millions of dollars. They're not billions.
Yes.
You know, it's really a fraction of the amount. But if you think of the impact, you know, you put up some slides there to look at the impact of a large volunteer program, and it was dramatic. Kids were getting treated, or the health impact was tremendous. And in addition to that, the sort of ability to support people, get their hearts and minds behind sort of a community narrative, this idea that we're in it together. So that long preamble to the very simple question, you know, having struggled with a program that was really underfunded for so many years with many donors that are coming in and out, what advice would you give this movement to professionalize community health workers? You know, what do you think people can do to really move away from volunteerism and get towards professionalization?
You know that actually we should try few things. First of all, if we start some projects, we have to think about the sustainability of the programs. Because if this is going on only on project based to not be sustainable for the future after the ending of the project, it will not have more benefits. So therefore, in Afghanistan, we know, we have had at that time a lot of, as we said, a lot of donation, money from US and from other peoples. But this was not provided to the health once. And secondly, this was not for all that, we didn't know for how long it will be. Because for the future, the government we understood that if the donation of the world community stop, there will be nothing. So therefore, actually, I am so sorry to say that in the last 20 years, we do not work for the sustainable a program of the Afghanistan for the future. They should follow by themselves. And therefore, there was not sustainable system in the Ministry of Public Health or other programs. So therefore, we will worry about that for the future. If you pay some time and then you stop, so the program will collapse immediately. So therefore, we do not. For the time being, my advice or my experience, according to my, we should because it is difficult in countries like Afghanistan. The poverty is a big issue. And if we do it, we give something. But we should, I don't know, how can we find the resources? We will already start with the UNICEF, WHO, and health authorities these issues. To how can we pay to the community for this also for the sustainability of the programs, to keep alive these children, the CWs in all the elements. But for I think that's not a big issue. There's no need to pay them a high amount of the monies, but at the level to at least to they remunerate and they will get the money what they spend in the programs. So this is for the future. In the past, unfortunately, we were not able, and we do not. If, for example, at that time, if we request the USAID and World Bank and other donor to pay these elements or the CWs, so may they accept that. But now, after this 20 years, they stop. So emergency, the program may collapse, but still we have volunteer are working.
Yeah.
So for this reason, we are.
No, and it's a testament to their incredible dedication, despite all of the changeover of governments and the back and forth between who's in power, the volunteers are still there taking care of their community.
Yeah.
So what, anyone else want to ask any questions as we wrap it up? Anyone else have any final questions?
As I said, could you take some picture at this time?
Yeah, sure.
Because
Yeah, definitely. We'll use this. We're gonna have this presentation up on a file sharing service like YouTube or something like that.
yeah,
Video sharing service.
I don't know why these people they not understand my presentation or
No,
what
it's
they do not have any questions.
they're very polite.
Yeah, I know.
And that's why they don't ask any questions.
So I hope just as a joke, I said. So thank you so much for you all to be with us and hearing to us. And if you have I would like to learn from you people. If you have questions, I will learn from you if you share your experience and knowledge. And hope to see you, most of you people, in the future.
Well, Dr. Birico here, Matthias, he has a question. Matthias, go ahead.
It's just a quick question, and I apologize if I missed this at some point in the presentation, but it was just about integration of the community health workers with the health centers, and just like, and not just data, but like the relationships that they had with nurses or physicians, and just kind of like how that worked, how that interface worked.
Yeah, so how did you integrate the community health services with like primary health care and other areas, the referral networks and whatnot?
Yeah, we tried to convince the authority or Minister of Public Health and with the other key person in Minister of Public Health, we should include this all community-based program in the systems.
Right.
And it was accepted, these 5 elements what I discussed, this is a part of the health system in Afghanistan.
Right.
So this was finally included in the system, and even their reporting is regularly coming to central HMIS of Minister of Public Health, and this is included in the report. So I mean, so this is they were accepted, and this is now the community-based care program is the official program of the system still. But we will see for the future how it's going, for how long and how it will be improved.
Fantastic. Well, thank you, sir.
Thank you so much.
Thank you,
Thank you,
Dr. Arwal.
Thank you, and to provide me this chance to share our experience, and hopefully sometime to have more time and to discuss more about it.
Yes, and this will be available. So if other questions come in, Dr. Arwal is going to be available here in Boston for quite a bit and is doing already engaged in some really interesting work, trying to engage with other Afghanis in Boston.
Yeah.
As you can imagine, they're in a real period of transition right now. So thank you guys. Thanks everyone for joining, and we will stop recording now and we will see you later.
Thanks.